Hey, Cam followers! It is Hannah and the lovely Kathy, a really great friend of mine, here to give you a bite-sized chunk about the neuroscience of pain. Now, why are we doing this? We are doing this because A, we love to educate and help you guys, but also we've got an event coming up that I do want to tell you about. So me, Kathy, and the lovely Bobby are doing an event on the 5th of December, and it's all about pain and behaviour. So we're giving you a little bit of a tantalising morsel about what is to come. So if you're interested in pain and behaviour, then please do have a look at this event. I'll put a link in the description so you can go and have a bit of a nosy. But back to topic in hand tonight. We're going to take you on a little journey. But first of all, Kathy's going to introduce herself and tell you all about what she is, what she does, so you have absolute faith in what she says.
Hi, I'm Kathy.
Quite harder.
Hi. So a lot of you probably already know me. I'm a veterinary surgeon and I'm also a neuroscientist. And I am also a resident in veterinary anaesthesia and analgesia. Actually, I'm not, because I've completed my residency, but I'm in that weird in-betweeny phase in between the residency and...
Okay, enough. And let's continue.
Yeah, see, Kathy was easier.
Kathy was so much easier.
So anyway, all of that is, I've got an interest in the brain, an interest in pain and painkillers and analgesia, and an interest in veterinary medicine.
And a massive interest in behaviour.
Yeah. Oh, yes. Yeah. So I'm also director of Barking Brains, which is science outreach. So I basically provide neuroscience content that's relevant for the behaviour and training community. And I've become increasingly interested in the neurobiology of pain and behaviour, partly because, as a lot of you will know, some behaviour clinicians have reported that up to 80% of their caseload is related to pain as either an underlying cause or a aggravating factor in the behaviour case. But I think actually, for those of us that live with dogs in chronic pain, we also know that the other way round, in that chronic pain can also change the animal's behaviour, and not just in terms of its likes and dislikes, but also in terms of how tolerant it is of certain activities, how sensitive it is to noise, how likely it is to be aggressive, all of those sorts of things. So it's a real two-way street, and it's really, really fascinating. As a neuroscientist, I find it amazingly fascinating because
definitely. And that paper, which anybody wants to find, I will put a link. It's Animals. It was, I think, February 2020. It's a really, really good paper to read. It's not too difficult. Probably take you half an hour to an hour. But it divides it into 4 different aspects of pain and behaviour, direct links, associated links. But something that they didn't include in that paper, which fascinates me, is how behaviour can affect pain. And for me, what I find really fascinating is when owners say, oh, we wouldn't do it if it hurts. And I love to reverse it, because we need to help people understand actually they would. And as their advocates, as their caregivers, as their brains, we have to try and foresee when they're going to overdo it, when they're doing things that are actually going to make their disease state worse. And in the long run, they're going to be more painful, which is what we're trying to prevent. So today,
I was going to say, like, on that, there are kind of 2 stages to that, because there's like the perception of pain and how well it correlates to what's going on biologically. So, whether the animal is actually damaging its joints. So how well their perception of pain correlates to that damage. But there's also the fact that the intensity and severity of pain, we know, doesn't correlate consistently well with the actual damage to the nervous system itself. And there's a complete mismatch in some respects between those 2 things. So hopefully we'll come on to that, because I'll maybe talk a little bit about the pain pathway. But basically, the majority of the pathway that's responsible for our experience of pain actually has very little to do with what the nervous system is doing in terms of firing. It's much more to do with the processing of those signals. So
and I think
that's up and the damping down.
Yeah, and I think because there's no way to really predict the response, the perceived pain for the actual physiological damage to the tissue, that we have to go by the rule of pain is what they tell us it is. And that's really important. So a real take home, the first big take home is, no matter what the x-ray says, no matter what you think it should feel like, you have to listen to what they tell you it feels like. And that might mean that you've got a 8-month-old golden retriever whose perception, their living experience of that pain is dramatic. And when you're looking for that trigger, what the initiating cause is, you're like, well, surely that can't be that bad. It doesn't work like that, does it?
No, not at all. Not at all. And there's really good neurobiological data to show, for instance, that positive emotions generally inhibit pain, regardless of what the arousal level is. But the arousal level itself is a confounding factor when we come to negative emotions. So negative emotions with high arousal tend to inhibit pain, but negative emotions that are correlated with low or moderate arousal actually enhance pain. So you get a hypersensitivity and an amping up of the pain response. And what's really interesting is it's not just, you know, in your head, as it were. I mean, that doesn't really exist. As a neuroscientist, you don't really think about things like that, because obviously everything's in your head, it's in your brain. But, you know, people often think if it's in your head, it's not real, like there's nothing real going on. And it's been shown that actually that isn't the case, because the emotions share the same pathways as pain processing. So the emotions are actually changing the sensitivity of pain receptors and how those pain receptors process the pain signals and which neurons they pass those signals on to. So yeah, it's such an individual experience, you know, which I think we know from talking to friends and family about pain, that pain is a very individual experience and a very emotional experience. But we can see that in the neurobiology, because those different emotional systems have different impacts on receptor density, receptor sensitivity, receptor shuttling to different types of neurons, whether they're serotonergic neurons or adrenaline neurons, etc. So which neurotransmitter they're responsible for releasing. And the combinations and permutations that are possible are so vast that it makes that experience of pain completely unique.
Yeah, absolutely. And taking it back to Hannah Lill, so the picture on the right is the brain and Hannah is the interpreter. That for me, when I'm trying to help owners, is all of those additional extras that you think, well, that's not in the pain toolkit because that's not a drug, that's not therapy, that's not going to do anything. You're like, whoa, no, it so is. Right. So when people talk to me and I'm saying, I'd really like you to get a snuffle mat, I'd like you to invest in licky mat, I really want you to start scatter feeding, I really want you to change the environment, I want you to bring leaves home so they can smell the outside world, I want you to have a positive attitude around them, I want you to, and they're like, is she barking mad? And like, no, I'm actually giving you a freebie pain influencer. And I think people often brush that aside because it just doesn't feel important enough. How could that really have impact? And
it's so important. I mean, there are a number of studies that have shown that there's a difference in the way that the body responds to endogenous neurotransmitters as opposed to pharmacological interventions. So pharmacological interventions we know are great. Like, definitely if I have a headache, I'm going to take some aspirin or ibuprofen or paracetamol or whatever. But in terms of the effect that they have, they're actually pretty poor compared to the endogenous processes. And endogenous processes and downregulation of the pain pathway is much more effective in both acute pain and chronic pain. And that's been shown in a whole variety of models, including severe pain models. So including those associated with surgery, which is probably the most severe pain that humans are going to experience. So if we remember that things
like... Why is that the most severe? Is that because they know it's happening and that it's out of their control and there's all the perception of... Because how could you say that surgery is the worst form of pain? Why isn't gunshots?
Should we run a study?
Let's do a study on this one. I think that's a profound statement that you have no evidence to back up that surgery.
Oh, I think you're probably right. It is a profound statement that I have no evidence to back up. So yeah, it was kind of more looking at elective pain induction. So yeah, you're quite right to pick me up on it, because I'm coming from an experimental point of view. And in terms of experimental models of pain, that's the most severe experimental model of pain that we can have. But in terms of the most severe pain, most of the severe pain models that have historically been conducted that are no longer ethical to conduct would be things like shearing forces on bone, or bowel distension models, those kind of things. Yeah, I know, horrible.
Abdo pain is just
visceral pain is hideous.
Yeah.
But yeah, I mean, to take us back to like, there's so much we could go into, but we're not going to get to it all today.
No, so let's pause. We're going to be here next Wednesday and the Wednesday afterwards, doing these little bite-sized chunks, having a little chin wag, trying to impart you with some key statements that you can take away with you, and to just really inspire you about how incredible this area of science is, and hopefully take you on a journey that you want to just learn more. But before we get tangented, because my brain's going crazy, that I want to talk all about, outside influences, and something that when I heard this, it hurt, because animals can't foresee the future, the pain that they experience at that time. They don't see an end to it. So some people might argue, is that worse than what humans have? Because we can go, oh yeah, dental pain, but actually I know it's going to pass in a week, so it's okay. My positive mental perception that it's going to come to an end will influence how bad that pain is. And that's just crazy, isn't it?
Yeah, I mean, it works both ways. So one factor that can make pain worse is catastrophization. So humans have the ability to say, oh, I've just been diagnosed with a disease that is incurable, that is painful, so I know that my future includes pain. Like, I've just been diagnosed with arthritis, I know that it's not going to necessarily get better, so I know that it's going to be painful. And we can catastrophize that, as in, oh, I'm not going to be able to go wakeboarding, I'm not going to be able to go and do the London Marathon, whatever. We kind of add to that. But you're right that it can work both ways, in that dental pain is a really good example of incredibly severe pain. And we must remember that the closer to the brain the pain is, the more intensely it's experienced. And that's a kind of survival mechanism, because obviously you want to protect the brain. So you need to completely change your behavior if you've got pain near the head, because the head is particularly valuable.
Otitis externa, please, everybody that have dogs with ear problems, stop going, oh, he's just got a bit of ear problems. I hate that. And when you look at your ear and it's all ulcerated, and people are like, just getting the cleaning, and I'm sitting there going,
Yeah, I had a dental abscess that I didn't know I had, and I got on an aeroplane, and of course it had air in it because it had bacteria producing air. And so what happens? The air expanded and I was in such severe pain. I mean, I have no idea what childbirth is like, thankfully, but it was so severe that I couldn't think and I couldn't communicate. I couldn't swallow. I couldn't move. I didn't know whether my eyes were open or closed, because I wasn't using my vision. My brain just shut off vision, auditory processing, everything processing. It was just the most intense experience ever. So yeah, and that's a good example, because how did I kind of talk myself off the ledge? I talked myself off the ledge because I'm medically trained, by thinking, okay, this must mean I've got a dental abscess. They'll be able to deal with it. Worst case scenario, I lose a tooth, but that's not so bad. So I've just got to buckle down. The pain.
You're able to rationalize.
Kill me. Like, that's something that humans have the ability to know, is that the pain is not going to kill me. And so, yes, it's unpleasant, but, I'm not going to die. And animals don't necessarily have that. So, yeah, it's a double-edged sword, our kind of higher cognitive ability, and it can help us, but also hinder us.
Yeah, absolutely. So let's go back a bit before because this is how we talk. Me and Kathy just
we tend to talk 100 miles an hour.
We do. So let's go back to that beautiful, like simplified demonstration of the pain pathway. I call it the pain.
Want me to show you my screen, because I've actually got.
Yes. Can you share it?
Let me tell you which paper it's from, and then I'll show you the figure. How do I share? I'm not allowed to do this, but as long as you don't log me into Elsevier or whoever publishes it, we're fine. It's for the purposes of education.
Don't tell anyone.
Yeah, right. So I want screen 2. Share. You have to tell me what you can see. Can you see from?
I'm waiting for a box to appear that I'm just going to share. So it should pop up on a screen on my little control panel that I share.
Oh, so it says I've shared it. Hang on, share screen 2. He's on share screen. Blah, blah, blah. Share screen 2. Share. No luck?
No.
Okay. I'll share the screen that I'm on.
Yeah.
It just means I can't see you then.
Don't pick your nose while you're sharing it then.
No.
See you.
Right. Can you now see my screen?
No. You might be an amazing neuroscientist, but you're absolutely crap with IT.
It's not the only thing I'm crap at. What? I was really excited about being able to share that diagram with you. Can I screenshot it and send it to you?
Well, yeah, send it to me. Carry on talking, and I will do my damnedest to get it up for you.
Okay, so yeah, I mean, we often think of the pain pathway in terms of kind of the physical anatomy. So the idea that, you know, if you get a burn on your arm, that's the noxious stimulus is the burn. Yeah. And the receptors in the skin in your arm and potentially the muscle, depending on how deep the burn is, are responding to the noxious stimulus, and they're sending a signal along nerve pathways up to the spinal cord, and then the spinal cord sends the signals onto the brain. The brain processes the signals. You realize that you've had your arm burnt, and then you get various kind of pathways that can modulate that signal. But what we often forget is that a lot of the modulation actually occurs in the brain. So it isn't actually about that longitudinal signal. Let me just see if I can send you the screenshot. How do I send it to you? Shall I email it to you?
Yeah, can you email it to me? That'd be great.
File share. Mail. This is really interesting for people, isn't it?
I know. I'm so sorry. We should have actually talked about work before instead of having a glass of wine and catching up, shouldn't we?
Yeah.
Oh, you live and learn. You live and learn.
Live and learn. Right. Okay. I've emailed you the picture, which will kind of help you explain.
Carry on talking, and I'll find it.
You've got the lateral pain system, which is the kind of part of the anatomical structure of the pain pathway. So once the spine sends the signals to the brain, they go to the thalamus, which is like the center of the brain, if you like, that then sends signals to other parts of the brain. And key to the lateral pain system is that they're sending signals to both to the sensory cortices. So that's in terms of being able to locate what type of pain it is, where the pain is, and how serious it is. And if we think about behavioural changes, acute behavioural changes, that's the first opportunity for behaviour that may keep you safe from that noxious stimulus. So you're going to pull your arm away, and how quickly and how far you pull it away will depend on what your brain, your sensory cortices is telling you about what the intensity of the pain is, the type of pain, and how dangerous it is. But in parallel to that, you've also got the medial pain system, which after the signals have got to the thalamus then sends strong signals to the amygdala. And the amygdala is a brain area that we often associate with emotion. And the amygdala is in communication with parts of the prefrontal cortex associated with decision making. So let's say, for instance, the stimulus, let's say you were burnt by a person. So that stimulus also involves emotional processing of what that means. Is that person trying to harm you? Do you need to run away? The amygdala is a key brain area in that response, because the amygdala will process that pain signal and then add to it whether you need to add fear or anxiety or upset or whatever your emotional response is to that stimulus. And the amygdala will be in communication with your prefrontal cortex that will decide what you want to do. So you might want to punch the person, or you might want to run away. And partly that will depend on past experience and a whole bunch of other information that your brain integrates with those pain signals at that time. And just pause there for a second. So this is why I'm a neuroscientist. If you think about what I've just described and how incredibly complex it is, and how many brain areas are already involved, and all of that is happening in a split second.
That's what I was just going to say.
Right?
It's crazy.
It's incredible. It's completely and utterly incredible. And in parallel to those two systems, so the lateral pain system, the medial pain system, you've also got cognitive processing. So you've also got the kind of long-term processing of not just how shall I react now, but how shall I incorporate this into my experience? How is this going to change my behavior in the future? How is this going to change my relationship with that person in the future if that person burnt me? I maybe should have chosen a slightly less aggressive example, one that was more relative to
so predictable.
Arthritis.
Never want to get into a fight with you.
But sometimes the most extreme examples are the easiest ones to remember.
No, it's very true. But I think what you're alluding to there is when dogs start developing behaviors that seem a little bit outrageous. You're like, well, you know, maybe they've experienced pain and they're now like, well, I just don't want to go there again, so I'm going to do this and this, and every time I'm just going to do this and this because I know it's going to work.
Yeah,
and you're like, wow,
absolutely. And what we don't talk about enough is the effect that pain is having on our brain. So it isn't just the case that pain is processing that signal and modulating that signal according to past experience. The brain itself and the spinal cord are actually changed by that signal. Now, not so much with acute pain, although repeated acute pain has been shown to modulate the spinal cord and brain, but chronic pain has lasting effects. So it has effects in terms of which receptors are expressed and how many of those receptors are expressed. And this is where we start to cross over into behavior, because some of those receptors that are key for pain processing, such as serotonin receptors, glutamate receptors, are also incredibly key to certain behaviors. So moods, emotions, cognitive processing. But of course, the pain signals in chronic pain are changing the expression of those receptors. So those receptors now are not going to function in the same way as they would usually for mood and cognitive processing. So it's almost like a side effect of pain, if you like, a side effect of chronic pain. But then when the brain changes the way it processes that information about emotion and mood, that also has a potentially permanent effect on the brain. So it also has epigenetic changes associated with it. And guess what? They change the way that we process the pain signal.
So it's
yeah, absolutely.
But you know, when you meet people that just seem really negative and you kind of go, oh my God, you're really negative. Actually, could it be argued that's a little bit out of their control? Maybe they've had backache for 10, 15 years and life's just got really on top of them and they just don't manage to see the best out of things. I know that sounds awful, but is that
one of the changes associated with chronic pain is that your serotonin receptors become less sensitive. And serotonin is the neurotransmitter that's associated with a feeling of well-being and euphoria and happiness, if you like. And those receptors become less sensitive. And so your mood, therefore, changes in line with that. And that's one of the reasons why for chronic pain, we can't just focus on analgesics in terms of pharmacological intervention. Yes. We have to be thinking about how to focus on cognitive and emotional processing also, because if we're to control the pain, we have to limit the downstream effects on mood and emotion, because they will come back to bite us in the arse. They'll come back to affect the pain processing. And it's been shown time and time again in really large scale studies, both in animal species and in human species, that patients that have high levels of trait anxiety or mood disorder have much higher experience of pain, both in terms of intensity and severity of pain.
And also, I'm sure that I read about people are now being profiled before major surgeries, and if they have the tendency to suffer from depression or anxiety or any kind of negative mood disorders, they are a little bit concerned that could end up with postoperative pain. Is that true?
Yeah, so it's been shown that the incidence of chronic postoperative, long-term chronic postoperative pain can increase from 10% in the background population to up to 25 to 30% in patients that have trait anxiety before they have surgery.
Yeah. So yeah, there was talk of them being profiled, wasn't it? Before knee replacements and elective procedures.
Absolutely. And in elective procedures now, it may be the case that they suggest that surgery is not the best intervention, and that actually physical therapy is a better intervention because of the cognitive or emotional state of the patient before surgery, because they would be at a much higher risk of developing severe chronic pain postoperatively. And that's
anybody that's interested.
And that, like, again, I keep coming back to this thing. I have endless discussions with people that are like, yeah, you just need to get over yourself, don't you? You just need to not be so negative about the pain. But it's a physiological, anatomical change that's happening within the brain. Those patients don't have control over that. Now, there is some element of control, and definitely pretending that you're happy will have a good impact on your pain perception. They've shown that. You don't have to necessarily be completely convinced, but fake it till you make it, and that has been shown to impact positively on your pain perception. I know, right? But there is a large proportion of it that is out with control, and that's where we need to look at pharmacological interventions in terms of supporting mood and emotions, but much more importantly, non-pharmacological interventions. Why? Because the pharmacological interventions themselves change things like receptor sensitivity, receptor density, and the way that pain is processed within the brain. And we don't actually understand that to its full extent yet. So what we know is that we're providing a short-term relief for the patient, but we may be creating long-term problems in terms of mood and emotional processing or pain processing.
So choosing the non-pharmaceutical lifestyle changes it's a no-brainer. No-brainer.
Yeah, and actually it's been shown in animal studies that physiologically and anatomically changes the brain. So those non-pharmacological interventions change the way that the brain processes mood, emotion, and pain. So they're really, really important, really, really valuable. And I think people can notice that. Like, I've just been away for 4 days with all my dogs, and one of my dogs, little Dennis, is about 16 now, and he's sort of.
Is he there?
He's upstairs.
Oh, damn it, Dennis is cool.
He's under my duvet, and he's 16. He's arthritic. He's got cataracts. He's a bit deaf. Life's sometimes a bit of a challenge. We went away for 4 days, and I was a bit apprehensive because he doesn't like being in the van because it's not 5-star. But I took him away anyway. The weather was quite warm, and he got to go on walks in unfamiliar places, so new, novel places every day, and got to totter around. And I was very careful to make sure that those walks weren't with the big dogs. He wasn't under any time pressure. He could just potter around. By the end of the 4 days, he was skipping around like lally-doo. So his mood had improved so much that actually he didn't really look lame.
Can I tell you my story?
Well, not been.
Let me tell you my story, because exactly the same happened with Holly when we did the big walk in 2017. There's no way that she could have physically, structurally changed in the 8 days we were walking. It was the fact that she had 100% of my time in new, novel environments for long periods of time. And when I came back, my housemate went, she's a different dog.
Yeah.
She's not the same dog anymore.
You say not physically changed, but physically changed at the microscopic level, not physically changed in terms of
structurally, muscles, ligaments, tendons.
But in terms of receptor density, receptor type, receptor sensitivity, all of that changes minute to minute. So yeah, absolutely. On a microscopic level, she had changed physically.
Yeah.
So yeah,
let's do a couple of questions because we've already hit half now. We made a promise because we said we know what we like.
Taught the hind leg off a donkey.
Right. Let me throw some questions at you. First of all, I don't know who Lolly Do is, but I think I might have been saying Holly, which is the flagship from Holly's Army. But there you go. Next one, this one. But I thought long-term chronic pain usually leads to pain wind up more sensitive to pain. Good question.
Yes, the but at the beginning means that it must be linked to something I said. So if you just quickly type what it's linked to, because it kind of suggests I've contradicted
myself. I get
myself,
the impression that person thinks that always any kind of chronic pain will end up with wind up, but it's not actually predictable.
Oh, I see. Okay.
There's no figures in animals, is there? There's no figures to say of all the dogs that experience persistent nociceptive stimulus from the periphery, 15% will lead to exaggerated pain perception. We don't have those figures in animals, do we?
No, and what's really interesting is if you look at the human data, it used to be the case when we only focused on pharmacological intervention that all of those pain conditions continued to escalate. So chronic pain continued to get worse and mood continued to get lower, which influenced chronic pain. Now that our approach to human chronic pain has changed and we focus much more on emotional and cognitive stability and on interventions that are well-being focused rather than pharmacologically focused, there is a much higher cure rate from chronic pain, and I do mean cure, and also much better improvement in chronic pain states, such that patients are more likely to find that, yes, they have chronic pain, but the intensity and severity is decreased and their well-being is less negatively impacted. And that's we made the switch to non-pharmacological intervention. So that's the Bristol pain group, if you want to look it up in Google.
Yeah, you know, you send me the links because I'm still learning from you as well. So Danielle, you're absolutely right, but what I'm learning as a student in this is that nothing is 100%, and the human brain always wants to make something logical, don't we? That the path of least resistance is making sure it's logical and predictable, and this is a topic where it isn't.
And I think it's really important to remember all of these things are happening at once. There isn't one thing that's happening. So if you give a licky mat, that doesn't mean that the only thing happening in that dog's body is an improvement in its pain processing. It also may well have a deterioration in its pain processing associated with something else that's going on in its life. But you're offsetting that partially with use of the licky mat or enrichment. So it's multifactorial. You've got all of these things happening at once. And pain is a really good example of that, because actually the changes that I've been describing as if they happen uniformly across the brain. They don't. They happen in different brain areas, depending on what the stressor is, what the emotional and cognitive state is before the stressor, and what the emotional and cognitive state is before, during, and after the pain. That's incredibly complex already. So
that's like the lottery. The permutations are just insane.
Yeah, when you give a licky mat to a dog in arthritis, it's not going to have the same effect in the same brain area as dog number 2, who you give a licky mat to, who's got arthritis, because they have so many varying factors, their experience of life being one of them, but also their stage of pathology or their type of pathology. And
so that leads me on to an answer to many, 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 many problems involved with arthritis. So be it that you're starting a new pharmaceutical, and this talk is definitely not anti-pharmaceutical at all.
No, definitely not. Pharmaceuticals are great.
Therapy. It is our absolute responsibility to check whether what we're doing is working. It doesn't matter what you do, you've got to check whether it's working. And tomorrow we're me and Kirsty, who's one of the CAM team, are doing a talk about breakthrough pain. And one of the key take homes of this is we need to observe whether the chosen intervention is in that dog's best interest, because nothing comes with a promise. So we really need to educate owners about being semi-objective to the best of their ability, because a licky mat for one dog might be amazing, but for another dog, it actually is just
that's why for pain management, a lot of the advice you see on social media is actually not useful, because it says, oh yeah, I would switch to Flexicam, or I would switch to Loxicom, or whatever. Well, yeah, but there are so many factors involved in that individual animal's response. I mean, there are genetic factors. There's a whole literature on genetic and epigenetic factors that influence our pain processing. But then there are experiential factors, emotional factors, cognitive factors, lifestyle factors. So it's really so individual, and I think the only way that you can really know is to keep a diary. Even, you don't have to keep a detailed diary. I keep a diary. I miss out some weeks because I'm distracted with something else, or I only write one thing in it one week or whatever. But just having that information and being able to look back on it is really helpful, I think.
It really is. And I think so I was having to write my list of what I'm going to say tomorrow, and I just kept going back to own education, because they were like, so what would you do for breakthrough pain? I'm like, own education. How would you help people identify breakthrough? Own education. It is so important that we help owners, because they are.
Yeah, I think it's really difficult. Sorry to cut across you. I'm just conscious.
That's fine. You're more important than me.
And you don't say anything interesting anyway. No, I'm kidding. But it's really difficult for owners, because if you take your dog to the vet, your vet's got 10 minutes. And also your vet is your vet is the only person that can prescribe drugs. So they're kind of, they need to focus on that, because that's what you're kind of there for them in that specialist 10 minutes. But of course, what they really want to do is spend an hour with you and go through lifestyle and go through enrichment and go through physiotherapy and exercise. But they haven't got that time, and the setup isn't that way. And we haven't yet got to a stage where pain clinics are common and involve that holistic kind of well-being approach to pain in the same way as we have got those in human clinics. I mean, they're still relatively rare in human clinics, to be fair, but they are becoming more popular. There's one in
and to try and problem solve, and I am going to completely big up Cam on this because we're allowed to. It's just financially not practical at the moment. If you look at what that room is worth in that vet practice, to have an hour, you're looking at a vet's time, and if they market vet's time for 45 minutes and £45 for 15 minutes for the average consult, so that's instantly pushed it up to £180 consult. Then you've got everything else that's involved with that amount of time. It's just not financially practical. So that is why we have made online owner courses, so that vets can say, I can't give you all the information. Your brain's not going to be able to accept it all. So why don't you go and do this course and then come back to me, and we'll be on the same page.
And I would say do the course early, before your dog's even in pain. I know a lot of people on this live will actually have dogs that are already experiencing pain. But if we can get in there earlier, we can actually potentially impact or prevent a lot of the behavioural problems. If 80% of a clinician's caseload for behaviour are coming from dogs where pain is a factor that's involved, if we can get better at recognising pain, at offsetting pain and preventing diseases that cause pain by making lifestyle changes and modifications, we can actually genuinely impact those behavior cases, or just not experience them at all. And behavior cases are unbelievably stressful to deal with. And it is really incredibly difficult. And it can sometimes be difficult to locate pain as a factor, because of course, if you think about yourself, I often use my own example. I have really dreadful back pain, but most people don't know that unless I tell them. I mean, I happen to tell a lot of people, so a lot of people know, but but you wouldn't know to see me walking around. I can walk, run for a bus, I can bend over.
Can I just shut you up and share this, because it's made me laugh, and I'm trying not to actually laugh out loud. The idea of a human licky mat. I love that. I think we should actually start doing that.
I don't know where my brain's going with that, Lisa, but I don't think it's clean.
I think that's brilliant. And can I actually share what somebody said the other week, and I absolutely adored it? We should start making square balls. I love it. I think
actually, that's a really good idea.
It's really good, isn't it? Somebody just said it in the live. They went, I think we should create square balls, and I was like, such a brilliant idea. Such a brilliant idea.
Yeah.
Right, so this one up here is a sensible one, and then I'll come back to Laura.
We're supposed to be answering questions, not prattling.
Yes. I want to get you and Amber Batson together to talk about.
Is it Batson or Bateson?
I call it Batson. Should be called that. Yeah. Does the gut get involved? I noticed you mentioned serotonin.
Oh, interesting. So one of the effects of pain is that it increases the concentration of the enzyme that breaks down tryptophan, and tryptophan is a precursor to serotonin. So yes, it absolutely does involve the gut. And actually the gut has been identified as the second nervous system, if you like. Like, you know, as neuroscientists, we're obsessed with the brain and a little bit with the spinal cord, but it's just kind of hanging on to the brain as a tailcoat. The brain is the brain is
spinal cord to be so demoted.
Yeah, I mean, you know,
still amazing place.
But actually there is an equally important nervous system that is entirely focused on the gut, both in terms of shuttling information to the gut. So we know that if we feel anxious, we often also feel nauseous. So there's an interaction there that goes down from the brain to the gut, but also in terms of from the gut to the brain. And because tryptophan is taken in orally, so we eat substances like bananas, not dogs, although Nancy does eat bananas, but they have a high level of tryptophan in them. And tryptophan is the precursor to serotonin. Most of the serotonin is actually made in the gut. Now, serotonin has its actions in the brain and spinal cord, but most of it is made in the gut. So anything that interferes with tryptophan processing, as pain does, is going to have a big impact on both behavior and pain. And it may actually be that that is the primary route by which behavior can be affected before the signs of pain are noticeable. So it may actually be that you get behavioural changes before the body recognises that it's in pain, because one of the effects of pain is to influence tryptophan processing, and that is given priority by the brain over processing the pain signals in the early stages, where actually those pain signals are so low that the brain may well decide, I'm not going to amplify those, I'm not going to make you super aware of them, but I am going to be impacted by that in terms of mood, because it's changing the tryptophan and serotonin processing. So yeah, it's a really
I need to know more about this.
It's a really good point by whoever that was, who wasn't Lisa, because Lisa was the human licky.
No, it's Lynn. Lynn's great.
So yeah,
Lynn pipes up with great stuff. You need to tell me more about that.
And actually, there's a study in pit bulls. If you look online, there aren't many studies about tryptophan, serotonin, and aggression, but there's one study in pit bulls, fighting pit bulls, that showed that when they stratified them according to behavioural assessment, so those that were deemed to be too aggressive to be rehomable and those that were non-aggressive, and then they looked at their gut microbiome, their gut microbiome were distinctly different in those two strains of pit bulls. Now, what we don't know is whether that's cause or effect. So we know there's a correlation between the gut microbiome, which will undoubtedly directly affect tryptophan processing and serotonin processing, but we don't know whether that's cause or effect. And we also don't know what the pain profiles of those dogs were, because they were dealt with before.
Can you just deal with the cause and effect and share your funny ditty that I actually have shared, which was the cat sat on the roof?
Oh, I don't know where it is now. Have you got it? Have you got a picture of it?
I'll go and find it. I'll put it on the link afterwards. But it was just so good, because so many people do a direct correlation in a unidirectional way. So it's a photo of this cat sat on a bent roof, and you wrote, what was it?
I can't take credit for it. I stole it from somewhere else. Yeah. But yeah. Correlation is not causation. The cat didn't cause the roof to be bent, but it does look like it did, because it's sitting right in the middle of the bend. Yeah.
And you said that just very clearly there. Yes, we saw that the biome was different, but we don't know whether that caused the behavior or the behavior caused the change in biome. So it's one of those things of chicken or egg, or both.
A lot more work to do on that, and both are possible. We've seen in other experiments that both are possible, but obviously we don't know which came first, the chicken or the egg in that case.
Yeah. Let's move very quickly on to Laura, who I just love Laura. So here she is. She always says really sensible stuff. How do we know dogs can't rationalize or catastrophize pain when the emotional part of their brain is involved in pain perception? Go for it.
Yeah, I mean, we don't necessarily know, right? I think in terms of downstream effects of catastrophization, Do we see them? Yeah, I'm saying we don't see them. But one example, yeah, okay. So I'm going to talk myself into animals may be able to catastrophize. And it may actually be that some individuals can and a lot of individuals can't. Catastrophization doesn't make sense in terms of survival, right? It makes no biological sense whatsoever. Being able to be realistic about what the threat is makes sense, because you can make informed choices that then reduce the likelihood.
But we also do know that we've completely outbred the need to survive. We had
in
this argument the other
humans.
day.
Oh, are you talking about dogs or
Domesticated
humans?
dogs do not have.
Well, yeah, then it gets complicated, doesn't it?
Yeah, because we had this argument so many times.
So catastrophization has benefits to the human race because it can involve future processing of future events that may or may not have happened. Mm-hmm. We have no evidence for that occurring within animal species, and it doesn't make biological sense that it would occur within animal species. But I said I was going to talk myself into catastrophization. So as a vet, one effect, you'll have seen this, Hannah, that is very obvious is when you have a cat that's in the hospital, that is recovering from a major surgery, or maybe has a chest drain or something serious going on with it, and it refuses to eat, and it gets progressively more and more depressed and displays pain behaviors more and more intensely, basically isn't responding to any of the analgesia that you give it. You can carry on pumping it full of drugs, or you can listen to the vet nurses, because the vets will carry on pumping them with drugs, or you can listen to the vet nurses who have seen this time and time again, who'll say, let's cut back on the pharmacological intervention and sit and cuddle the cat.
Yeah.
And it has a huge...
Or in some way get the cat home so it's in its own environment.
Yeah, absolutely. A huge impact. Now, whether that's an example of catastrophization or not, we don't know.
That's fascinating.
Because we don't know, but it is possibly an example of catastrophization. Mm-hmm. The cat just gets progressively more depressed. And
they don't seem to want to fight their way out of it anymore, do they?
Yeah. So that is an interesting one, and you're quite right to pick me up on it.
Laura's amazing. Laura was absolutely instrumental in the big walk. Awesomeness. Let's have a quick look here. What's this? How about a very small free work setup on lead alternative? Oh, right. Yeah, we're talking about this one up here. Some other novel enrichment ideas for improving dogs' moods. Obviously, licky mats, snuff mats, stuffed kongs, etc. Any out-the-box ideas. Now, this is where Cam is amazing, and I'm so super proud of the community that you guys have created. Share ideas tonight, guys. Just write it down. You know, there's 66 people listening at this moment in time. All of you put down an idea of something that you do with your dog that you feel really, really enhances their positive well-being, their mood. I experimented earlier. I'll be so proud of this. So not that I leave things to the last minute like you do, Kathy. I think we're in the same boat on this one. So doing the talk about breakthrough pain thing tomorrow, decided to do a bit of a shout out on Holly's Army at 3:00 this afternoon.
That sounds like
hey, Holly's Army, give me some lowdown on what you think about breakthrough pain. And what was so cool, because it's such a gem of a place, I've had like 30 responses. So
wow,
this is what this community is about, is like me and Kathy and all of the other amazing people come in and we share our knowledge, but you guys can share your knowledge too. So please do put down
you have real life knowledge.
Exactly.
And you know, one of the things when we're talking about non-pharmacological interventions, we usually think about adding something to the animal's environment. So adding a licky mat, adding free work's an excellent suggestion, adding a Kong. But actually, just simply taking the animal out and sitting and watching stuff go by depends on the animal and whether that's anxiogenic or not. But if I take Dennis to the park, we don't go for a walk. I take him there in a bag, I let him out of the bag, and we sit there and watch the world go by. Then we get back in the bag and we come home. And he loves it.
He is the coolest. See, this is already working. People are putting in their ideas. So keep flowing, guys. I love it. I miss Dennis. Super cool. Aww. Me and Kathy were thinking about living together for a while until she got a boyfriend. But I think it would have been a disaster. I don't think we'd ever sleep.
We'd have a lot of laughs, though.
We would have a lot of laughs. We're still looking for our Netflix contract, aren't we?
Definitely. Yeah, I so want a Netflix show.
Cool. And on that note, we said we'd talk for 20 minutes and it's now 50. So I think what we're going to do is walk away and come back next Wednesday, leave you guys hanging, where we're going to take on the topic where we're going to look at more of the cognitive influence on pain. And then the week after that, we're going to look at more of the emotional influence on pain, and hopefully entice you guys to come and join us on the deep dive, which I'm really excited. I'm completely virginal to this. I'm really, really excited to be able to chat in a online small community environment and just discuss with the lovely Kathy and Bobby about Moose's story, and just give you guys ideas about case management. So please do come and join us. I will put a link in the thread.
And I like the thing I like about the deep dives is they're really interactive. So actually, you know, like you were just talking about, you learn from the community as much as you teach the community, and the deep dives have that at their core. There's you know, two-way conversation, and we really encourage people to be taking part by interrupting, asking questions, but actually giving answers as well. You know, people will ask questions, we'll give our answer, but there's a whole load of stuff in the chat from other people, and people are posting links to papers or links to other pages and stuff. So yeah, I really, really love the deep dives for that. It's a really good, fun day. It's intense, don't get me wrong, but it's so exciting because you get everybody taking part in it. It's really good.
Yeah, no, and I like that. And I think what we've definitely found with the CAM speakers, the people that come and share their knowledge, which, by the way, they do it for free, which is incredible, is that they're pretty humble folk, and they're
Hang
very
on a minute, I'm doing this for free.
I'm buying you wine. Why?
No, yeah, I cut across you. You're right. Yeah, everyone's amazing.
Yeah, no,
they donate their time and expertise.
Within my lifetime, I'm going to be at London Vet Show main stage talking about licky mats.
For people or for dogs?
Oh, for people. Wouldn't that be amazing? Vets, to get through a consult session, stick a licky mat to the wall, just intermittently between consults. Go and lose yourself, recharge.
Well, that's what biting your nails or sucking your thumbs about, isn't it? It's the same sort of repetitive behaviour.
Between consults, so.
Yeah, it doesn't go down very well. Oh my God, no. We're so off topic.
I know. We need to go. We need to go. Cool. And we will see you all next Wednesday. And thank you for joining us.
Thank you for joining us. Lovely to see you, not see you.